Hello, my name is Pamela Manner, and I'm the Chief Nursing Information Officer and AVP at UMass Memorial Health. I'd like to give you a brief overview of our poster that my colleague Ingrid Black and I prepared. The title is Integration of New Delirium and Dementia Standards into Practice, a Multidisciplinary Approach. We began this journey in response to a new Alzheimer and Dementia Act that was signed into law in the state of Massachusetts in 2018. This year, in 2022, hospitals licensed by the DPH must develop an operational plan for the recognition and management of patients with dementia or delirium in the acute care setting. And as you can see here, 6 standards are contained within the law. At UMass Memorial Health, we are a large system with an academic medical center and community hospitals, as well as outpatient services and ambulatory clinics. So we strive to take great care of our patients who have cognitive dysfunction, but as a large hospital system, we know that we get many inpatients with dementia on their problem list, and we have studied how our documentation is for these patients. And over a 2-week sampling, we noted that less than 5% of our inpatients 65 or over with dementia had a dementia care plan on their chart. So we decided that we needed to get to work on this and make sure that we really were paying attention to these 6 standards. So we began doing some goal setting. We got a multidisciplinary committee together, all different disciplines of clinicians, including nurses and doctors and advanced practitioners. And we did a gap analysis. And we found that we were providing great care, but we weren't always documenting that care in a way that it could be measured. So we looked at some opportunities in our electronic health record where we could standardize the information in a way that clinicians could more easily document the care they're providing to patients and be able to ensure that we are meeting the letter of the law. So our system uses a single electronic health record, and putting this into place will be system-wide and really helpful to our staff. Our design standardization goals start with the RN assessment. And upon admission, we're going to use the CAM for any of our patients that are 65 and older. And that will help to trigger the doctors and APPs to enter the appropriate diagnoses in our problem list, which can then be part of a grouper, which will help us to display banners in the charts so that all caregivers are aware of patients who have cognitive dysfunction. We also want to standardize our alert language. We have had some different ancillary applications build alerts, but each alert said something different. So we standardized our language to patient has a history of cognitive dysfunction. And we felt that everybody, no matter where they worked, would be able to understand this, especially with the education we're providing. And our aim was a global aim, so that no matter where a patient has an encounter in our system, if they have delirium or dementia, we can recognize that and provide the best care possible for them. So we have a clinician process here, and as I said, it starts with screening on admission. And in case we have a patient that has cognitive dysfunction who is under 65, we've also built in some triggers to our neurocognitive assessment. So we are able to use the CAM if there is a change in cognition for patients as well. The diagnosis is key, so we use that positive CAM to help alert the providers, the APPs, the doctors, that Their assessment of the patient, which leads to a diagnosis, needs to be documented on that problem list. Once they document it on the problem list, we're all set to start triggering all of our clinicians via charts, tickets to ride, and other means. Also, these alerts include adding care plans to the patient's chart. We can do that in the background and take some of that work away from our nurses and other clinicians. So if there's a positive CAM, we can put a chronic confusion care plan or a fall risk care plan onto the patient's chart. And those interdisciplinary plans of care also trigger educational items so that the staff remember to provide that education to patients and their families. And lastly, communication. The CAM displays in a comprehensive flow sheet for the clinicians so they can see that that CAM was positive. And the banners display for inpatient caregivers, clinical ancillary caregivers, and for ambulatory caregivers. The banners visible to clinicians indicate patients' actual or potential cognitive impairment. Lastly, across all patient encounters, we want to make sure that our clinicians are aware of our patient needs. So if a patient is newly diagnosed with dementia in an ambulatory setting, and the provider adds the appropriate diagnosis to the problem list, the banners will then be triggered on subsequent visits, no matter where the patient comes for care in our system. We also recognize that our transporters sometimes aren't aware that a patient might have a cognitive dysfunction. So we ensure that we put information in our ticket to ride and also information into our mobile transport application so that the transporters are aware. As I mentioned briefly, our clinical ancillary departments were seeking to use banners as well, so that when patients appear in radiology or cardiology or lab, if there are special needs, our caregivers will know about it. And lastly, education for our caregivers. Our licensed caregivers in the state of Massachusetts are required to complete dementia and delirium training if they're a nurse, a doctor, or an APP to get relicensed starting in November 2022. But not all of our caregivers are licensed this way. So we're providing education for our transporters, our environmental services caregivers, our dietary caregivers, and others so that everyone is aware of this important endeavor. That's a brief summary of our poster, and we hope you enjoy the poster at the ANIA conference this year. Thank you for your attention.